General overview from start to finish, from decision through insertion, through care and through removal of chest tubes. In your pack you'll find a test tube competency that we should cover all of those things, and there's a little hit list of takeaways from this that is a good sort of coverage as well. So we'll look at indications and relative contraindications and alternatives to chest tubes, equipment, where it's kept, look at the Plurivac system, drainage system, which is a dry suction system, even though it does have a little water in it. It's one of the dry suction systems. Insertion and management, dressings, patient movement, complications and troubleshooting, and removal. So it's a fair amount to cover. So the indications, first I guess we'll look at the anatomy, and I don't know whether you can see this or not. That's the diagram of the pleural space. It's in your pack also. So you've got the lungs in there, the heart in there, the visceral pleura, which is the layer around the lung, and the parietal pleura, which is the layer around the rib cage. Between those layers is usually just a little tiny bit of slippery fluid so that the lungs can expand and contract. Now, if air or fluid, be it blood, pus, whatever, enters that space, then you lose your vacuum, and the lung, that's what they talk about, a lung collapse, where the lung's no longer held out by that vacuum. So you hear different types of pneumothorax. A spontaneous, where it just happens. Skinny, long-barreled people are fairly prone to that, especially if they're flying in light aircraft, that sort of thing. Marfan's syndrome, Marfan's disease, I don't know if you know people with that, but they're long, skinny limbs.
Isn't that what Abraham Lincoln had?
Probably, yeah. Smoking could be a problem, and some people in pregnancy too can be more prone to them. So they can be spontaneous, they can be traumatic, like a good solid bump to the chest. Iatrogenic, in the hospital, insertion of a central line, and they always check to make sure we haven't done any damage there. Or it can be barotrauma. And then you'll hear them talk about tension pneumothorax. The main problem with a tension pneumothorax is that it's caused a shift in the mediastinal structures. So that makes it very dangerous. So if you hear tension pneumothorax, then that's why it's a problem. So fluid in the pleural space, usually what we see here is a pleural effusion in older people and cancer and that sort of stuff. It can be sterile, or it can be pus, or it can be malignancy. Be all sorts of reasons that fluid goes in there, including hemothorax, which can be from blunt or penetrating trauma, and a cardiac issue can cause it. Also post-surgery, post-op, you can have problems. So again, I don't know whether you can pick up on this well, but insertion's usually anterior or lateral. Maybe I jumped the gun on this a little bit, but it's usually for pneumothorax, second or third pleural space, and then for pulmonary liquids and things, it's usually pleural space intercostal space, 4 to 6 that the tube goes in. It's a radio-opaque line so that it can be x-rayed to check it's in place. It's usually anterior or lateral. So relative contraindications include if the patient's anticoagulated. But as I say, usually if they need a chest tube, they desperately need a chest tube, so they might need to use vitamin K or whatever to reverse that. Coagulopathy problems, if there's an overlying chest infection, skin type infection, they might need to just cover that with antibiotics and carry on. And it's always best to use an ultrasound to guide the placement, not necessarily right there in the room, but get an ultrasound and see where you need to go, especially if the patient's had adhesions and has had a thoracic surgery or a previous pleurodesis, where they pop in talc or doxycycline or something like that into that space to cause fibrin, to close it up so the space no longer exists uniformly. Some alternatives, needle aspiration, and then they can put in a smaller tube and attach a Heimlich valve, which is this little fella here, and I might have one further opened up further down too. So the Heimlich valve just attaches to the end of the tube, and it allows air movement one way. It's only good for air, not for liquids, of course. It only allows air movement one way, so air can come out, but it can't come back in. It's got a little flap valve in the thing. And then, let's see, needle aspiration we talked about. Usually that's the first go, especially here you'll see in the older patients, you'll see a lot of needle aspirations of fluids, and also sometimes they can try that for air in younger people. And then this is the latest little gizmo that's relatively new here. There's a little, it's like a surgical drain in that, this tiny, has a tiny little tail that goes inside, and then you create a suction and it sucks it out into the thing, and you create a suction again. So it's just a surgical drain really. And I think the only time I've seen it used here was for lung abscess. It's not going to hold enough fluid for anything major at all. But you might see that around, and just needs to be measured and emptied and squeezed on a regular basis. But that's the newest little gizmo. Okay, so the equipment. You're going to need a chest tube insertion tray, which is this honking great thing here. This is in the bottom of procedure cart number 2 in the unit. There's also one in the ED room 2 in a plastic tote. And I found out there's also one in PACU in the back left corner in a cupboard by the sink. Just directions I was given. And then there's supposed to be one spare kept in sterile supply. And then if all else fails, the supervisor should have the number of an on-call tech to come in and prep anything you need. But there should be plenty of these around and available. Just put that down there for now. So, let's see. Okay. So here's that Heimlich valve. You can see But air's only going to come out obviously that way, and if air's coming in this way, it closes the valve off. You'll see them occasionally. All right. So the other kind of supplies you're going to need, obviously you need all this set up before you get going. You're going to need sterile gloves, masks, eye protection, all the PPE stuff. Some benzo and iodine and chlorhexidine, lidocaine 1%, and maybe some pain relief and light sedation for the patient if the situation and their stability allows it. So you get that all set up. Come back to that later. So this is in your sheet too. This is the list of what's in that pack, chest tube pack, and also gives you a little list of other things you're going to need to add to it. But there's most of everything you're going to need in there. So you're going to need that, and you're going to need your Pleurovac 6000, which is this little gizmo here. I don't know what that is. It's other junk. Okay, so the Pleurovac A6000, I think I'm good there. You're going to need this to set up, and there's a couple of things on the Pleurovac in your sheet as well. All the parts is one sheet, and then there's nursing considerations and troubleshooting is another sheet you've got there. But the Pleurovac comes obviously sterile, has tubing in the back. Whoop. So you're keeping it sterile. This connects to here. This end needs to be kept sterile because it's going to go to the doctor later. He's going to pop it in the chest tube. It comes with a container of water, twist top, and you pour the water in your top suction spout here, twist that off and squirt it in. Have you used one of these before? Okay, so the water comes down here, it changes colour to blue, and it should sit a little bit under that, the white line there. And that part there is your leak meter. And you'll see it's got smaller to larger bars. If you see a little bit of bubbling over here, then it's a very minor leak in your system. This is once you're all hooked up and have suction. And if you're getting bubbling further on, the further along, the bigger the leak. And we'll get back to that a little bit later, but that's your air leak meter. And as I say, the water goes in there and turns blue, and it'll come up here somewhere. And all you'll need is 2 more hands. And as I say, you keep this end sterile. So I guess I'll spend a bit more time on this. It has a twist out click stand because you don't want it knocked over. Now, and it has hooks. You hook on the bed. Some people like to tape this to the floor. There's a diagram in there of one with a mobile patient where it's taped to an IV stand, which I thought was a pretty good idea. Younger patients can walk around with their chest tube. It's in there somewhere. All right, so once we're all in, and we'll get back to that procedure again a bit later on, the doctor will tell you whether he wants suction or not. So this is the suction control. It's preset at 20, but it can go all the way from 10 to 40. Usually they start at 20, and usually it's always just 20. So you've got your water in here, your blue water, your little thing here, you've got this set. This is where whatever comes out of the patient, if it's liquid, comes out here. And generally what I do, and you should do an INO on it every 4 hours if there's any volume coming out. And then at the end of the shift, I generally mark date, time, and where it's at, so that we're keeping a close eye on what's going on. Now, if suction is ordered, and it usually is initially, at least, you connect your long suction tube to your suction spout, and that goes to your suction canister up on the wall. And you turn up continuous suction. You know, you've got a choice there, intermittent, continuous. You turn up continuous suction until you get this little orange float pops up into that screen. Now, no matter what suction the doctor's ordered, whether he's ordered 10, whether he's ordered 40, you set the dial to what he's ordered. You turn up the suction slowly until this thing appears in the window. That's your suction. It's nothing on the dial, on the wall, it's all here. If this is set to the order and this orange thing's in there, you're good. Any questions on that so far? So a couple other little gizmos on here. If for some reason there's got extra fluid in here or whatever, this grommet can be wiped down and you can use an 18 gauge to draw out fluid. Sometimes, if the patient's having like a coughing fit or whatever, this little white ball float there, that can be pushed up right up to here, and it stays up there. If the patient is on suction, only if they're on suction, so this little black button here, you can push that until the ball drops down again. Don't push it if they're not on suction, because you'll allow air back into the lung space there. Any questions on any of that so far? It's just getting used to the machine. Okay. As I say, there's some troubleshooting sheets and stuff like that in there as well. So this sheet that you see in there is for after your insertion, and it's just of where everything goes. And basically, there's a dirty utility in the unit there. There's a bucket or a container. Anything used goes in there, and anything unused goes on the counter, covered, and then sterile supply comes and picks it up and cleans it up again. Okay, so have we covered everything on this setup? So the same deal when you're inserting as when you're changing out. You get your new one ready to go before you do anything else. You keep the patient end of the tube here sterile. You use the attached water container to fill through the suction port, and the water turns blue. Turn the suction dial to the ordered suction. It's preset at 20. You connect the suction tubing from the wall unit to the suction port if suction is ordered. And once it's connected to the patient, turn out the wall suction continuous until the orange float appears in the window. And as I say, as long as that's dialed to the suction he wants and the orange float's there, that's what you're getting. It has nothing to do with the numbers on your suction thing on the wall. Okay, so the decision to admit, generally therefore, large or expanding hemothorax or pleural effusions or pneumothorax, 25% or more that needle aspiration hasn't worked for. or 50% or more, or a tension pneumothorax. Remember, tension is more dangerous, so we want to address that. So that's the basic guidelines for inserting the tube. Remember, it's a sterile procedure. It requires a consent and a timeout. As I said,
What about in an emergency? What about in an emergency?
in a trauma case, then it still requires a timeout, but the consent will be obtained at a later date. But that's a true emergency. That's like an ED trauma thing. It's commonly inserted, as I said, intercostal space 2 or 3 for pneumothorax and 4 through 6 for a pleural effusion. It's usually anterior or lateral. So you gather all your supplies, consider pain and anxiety meds, assess your patient, including listening to their lungs, and obtain a good set of vitals. You set up your Pleurovac. You assist your physician to set up all of his junk from in here, or her junk from in there. You help assist positioning the patient, perform the timeout, support the patient through the procedure. It's scary, even, they use lidocaine, but some doctors are faster at going in after lidocaine than others, and it can be painful, and it's scary anyway, so be there for your patient. Connect the Pleurovac to suction if it's ordered. Apply or assist the surgeon, the doctor, in applying the dressing. Take the chest tube to the patient, distal to the dressing. We'll go into that again in a minute. A loop and secure tubing to the bed. Pleurovac stays below the chest level, and it can be secured to the floor or hung from the bed. Those hooks are just for hanging from the bed. They're not to carry the machine. They're not they're not strong enough, especially if it's full of fluid. Always use the handle. If it gets knocked over, it can be righted. If it's fluid involved, it may go between the different lines there, so you may need to change it out just to keep a better eye on what's happening with fluid removal. But generally it's not the end of the world. It's just you don't want it knocked over and not seen knocked over. Then you're not going to get proper suction. Reassess your patient after the tube's in, obtain some vitals, and you need to get a chest x-ray. Then you've got that picture of the Pleurovac hooked to an IV pole so the patient can move around if they want to. A lot of our patients don't move around, but you're actually, when you're looking after a patient with a chest tube, you want them to be moving, at least moving in bed, coughing, deep breathing. So you've got to make sure you've got adequate pain control, because you don't want them just laying there, not taking a little shallow breath. It's going to slow everything down. So, management. So you instruct the patient to report any breathing difficulty, not to sit on the tube, lay on the tube, play with the tube, pull the tube. They have to be on continuous pulse oximetry, keeping a good eye on their vitals and their system assessments. Generally Q15 for the first hour after the insertion, and then at least every 4 hours. In fact, most of the chest tubes you'll see here are out on med-surg more than CCU, because the ones we would see normally would be traumatic, and then we don't have a thoracic surgeon, so we don't keep them. But you'll see plenty of them. Then you chart it every 4 hours, talking about the suction setting, the drainage, description, volume, INO, that sort of thing, swing and bubble. You'll hear people talk about swing and bubble in the tubing and in the chamber there. I'll cover a bit more of that in a minute. So you're also looking for shortness of breath, pain, asymmetry of the chest, anything like that, cyanosis, drop and sat, subcutaneous emphysema. You know, have you ever felt subcutaneous emphysema? It's like Rice Krispies under the skin. It'll snap, crackle, pop as you... it's normal to get, well, not normal, it's common to get a little tiny bit on first insertion that should reabsorb, but if you get an expanding amount of that, that's a problem. You've got a leak there. So what else? So usually you do a chest X-ray and insertion, and then usually they do one every day to check for expansion of the lung and decide when to take the tube out. Pleurovac's kept upright below the chest, no kinks, no dependent loops in the tubing, and no routine clamping and stripping of the tube. So everybody keeps these in the room, these clamps. And it used to be common if you were going to move your patient around back in a long time ago, you'd just clamp the tube. Trouble with clamping the tube, the idea was to avoid any accidents, but every time you clamp the tube, you change the thoracic pressure, and so it defeats the purpose. So you don't routinely clamp the tube. The tube also has its own little clamp here in case of emergency. And then another thing nurses used to do was if there's a lot of fluid and there's junky in there and you want to get it moving, you think it's blocked, they'll strip the tube. Imagine what that's doing to your intrathoracic pressures. So you don't do that. You can do a little bit of this sort of stuff if you've got blocks you want to get through, but nothing more than that.
When would they clamp it?
They used to clamp it if you were moving your patient around.
Well, like now, when would we clamp it? In what situation?
Only if there's you're dislodged from your machine, that sort of stuff. Only severe stuff, and they clamp as little as possible. But you do, and when I talked about kinks in the tubing, I mean, obviously you don't want kinks. You don't want dependent loops, which is this. It goes down and goes up, because then you've got to suck out of that loop, and the suction might not do it, so you're just going to end up cutting out, negating the suction with that, or with loops like that, where they cross over. So you don't want any of that. You want this down on the floor, this up on the bed, and you can tape it at different spots so there's no looping. It's just straight down. Okay. So, in the patient's room we do generally keep, as I say, this is mostly old habit, keep 2 drainage clamps. These are don't have teeth, so they don't have to have the rubber stopper over them. The older ones, they'd just put rubber stopper over ones with teeth. These won't do you any damage, so they're okay. So you keep a couple of those ready, available, and obvious in the room, taped up against the wall or something like that. Some Vaseline gauze or Xerofoam, a couple of packs of sterile, that's what I forgot to bring, sterile drain gauze. You know what drain gauze is, right? That's your normal gauze with
The key-drain ones? Yeah.
with a slit. And then tape and a bottle of sterile water. And we'll talk about the bottle of sterile water a bit further down the line here. This is the rubberized tape is really good for these, because it seals really well and it's stretchy and all that sort of thing. So let's see. Before we go any further, now let's say the doc's put in an little anterior chest tube, and you've got your dressing here, which is generally they'll put some Xeroform gauze around there. They're saying these days that maybe that's counterintuitive because it can mess up and loosen up your sutures because they're supposed to suture in, but most of the docs will still do it. So that's wadded around the insertion site. Then you've got your drainage gauze over the top, so it's well padded, and then it's well taped, here, here, so that it's secure. Now, obviously, all these little holes have to be inside the patient. This is just an example. And then another good thing to do, I was talking about that taping the tube distal to the dressing. A good way to do that is to make a little connector like that, and be more tape, but then that's taped to your patient and it's not stuck on their chest, so that you're not causing skin breakdown or anything like that, and that's good and solid. Then that is hooked to that. This is only a tiny little thing and that connector's too big for it, but the real chest tubes are bigger than that, and that connector just fits in. Okay. So the dressing gets changed as ordered, every day, every 2 days, or if it's soiled or wet, or if you think there's a leakage problem. You encourage coughing, deep breathing, arm movement, active or passive if they're not able to do active, repositioning and mobilizing in the bed. If they're bed fast, then they should be fowlers and move side to side. And ensure adequate pain control. How are we doing for time? So, the things you want to talk to the physician about, and most of this stuff you want to fix first and then talk to the physician about. But patients having breathing difficulty or tachypnea or falling SAD or cyanosis, do a quick check for displacement or disconnection, any major leaks, kinks or blockages. So it's just following your circuit basically, and with the machine there you can tell if they've got a bigger leak than before by the bubbling in the leak chamber. If it's dislodged, that's a rapid response. Call a rapid response. Have the patient cough and exhale as much as possible, and put a petroleum gauze taped three-sided, a flat valve, have you ever heard of that? So basically, you've got your dressing on here, it's taped here, it's taped here, and it's taped here, so that air can still escape, but basically a similar sort of thing to your Heimlich. So that's a rapid response situation. Get a chest x-ray, and again, if you're disconnected at the tube, between the tube and that, probably another rapid response, depending on if you're right there when it comes disconnected, and you can hook it straight up and the patient's not changed too much. But any doubt, that's a rapid response also. At that point, you can block or clamp the tube briefly, swab the end and reconnect it. Unless it's grossly contaminated, then you have to see the doc about what to do from there. You can clean, reconnect and unclamp. And get a chest x-ray. If for some reason the water seal, Pleurovac gets damaged, you can remove this end. Say this gets kicked over and cracked and is leaking or whatever, obviously it's no good. You take this end off and you stick it in here, and you bottle of water down on the floor, just to make an underwater seal so that air can't come back. So that's what this is for. And then you just prep a new Plurivac, hook her up, unclamp, and away you go. Get a chest x-ray. Often you'll get some bright red blood initially, but if you're getting bright red blood more than 100 ml an hour after the first hour, you need to let the doc know about that. If there's a stop or a drastic drop in drainage, have the patient turn, cough, deep breathe, it's probably a blockage somewhere. Check the tubing, auscultate the chest. If the chest is quiet, that's a bad sign. You need to get a hold of the doc quick. If there's a spread of that subacute emphysema that I talked about, that can be a problem. And a worsening leak. You check your insertion site and connections. It could be a pleural fistula, it could be at the side, or it could be somewhere in your tubing. Remember, you've got that air leak meter down in the machine to check. So there is a technique for figuring out where your leak is, and the first one, your first step is to squeeze around the insertion site, make sure that's well covered and secured and the tube's actually in place. If that bubbling stops with that, then maybe it just needs to be redressed, or maybe there's an actual problem where it's out a little bit, where one of these eyes is out a little, and it needs to be repositioned, that sort of stuff. And then you take your clamp and work your way down your tube, clamping for no more than 10 seconds at a time. So clamp here. If the bubbling stops, the leak is probably here. Clamp down here. If it doesn't, clamp down here. If the bubbling stops, then there may be a leak in here. Remember that this is not self-sealing. Never take samples from this for any reason. It's not self-sealing, and if it gets run over by the bed, it may, perforate or crackle. So you could get a leak down here. Doesn't change, check down here and clamp all your way down. The leak is going to be between the clamp and the patient. That's why you start up here. All right, so that's fairly basic. Clamp. Remember not to clamp more than 10 seconds for each one. And then, of course, if there's signs of infection, you need to let the doctor know. Then there's that sheet that talks about dope, or it's a mnemonic for check for displacement, obstruction, pneumothorax or worsening of the condition, and equipment. Check your wall suction, check your tubing, check your Plurivac. So the sample port, if you were asked to take a sample of anything coming out of the chest tube, is here. Alcohol wipe, Luer lock. Take your sample. You may need to cause an obstruction or a loop for a while to get your sample into here, but that's where you would take any samples, and it is rare. It's rare to do. But never stick a needle in here is the main thing. Okay, so we talked about tidling and bubbling in your columns here. Now, in here, sorry. So the ball moving up, the fluid moving up and down, or maybe some bubbles, and you're more likely to be able to see that if the patient is not on suction. When they're on suction, it's hard to see it, because the suction counteracts their breathing, you know what I mean? So you can get them to cough and deep breathe and see if you've got some swing. You don't necessarily have to have bubbles, but you should get some swing. There's that. And if you're not, well, maybe the lungs are fully expanded. So I don't believe I've ever had any doctor ask me, but the way to check the negative pressure in your chest cavity with this system is to add your dial pressure to the height of the fluid. So if you dial the pressure of 20 here, and your fluid is that 5, then the negative pressure is 25. If it's not the suction, the negative pressure is whatever this is, maybe 10, maybe 5. Not too terribly significant, but if you ever hear that mentioned, that's what they're talking about. We talked about the float valve getting jammed up here. If they're on suction, press that and you can pop it down. We talked about dependent loops. And we talked about adding or withdrawing extra water from the sterile water from the air leak meter using an 18 gauge syringe after alcohol wipe. So removal. Usually the chest tubes are in for about 7 days or less. And the physician makes their decision on withdrawal. It's usually after drainage is less than 150 over the last 24 hours, and there's no air leak for 24 hours, or there's a small stable hemothorax and pneumothorax left. Then they'll take the tube out. They may leave them off suction for several hours before removal, just to see what that does, see if there's any build up again. So you go to your supplies, your PPE, sterile gloves, masks, that sort of stuff, Zeroform, tape, 3 inches tape, gauze. You assess your patient, you get some vitals, you wash your hands, you don your PPE. You advise the patient to take a deep breath and hold it and bear down, like you do with a Valsalva. If on the ventilator, you can have the RT present to perform a respiratory pause on the ventilator, which will do the same thing. The physician might partially prep their dressing to go on the wound, and you can help them set up and help them do that if they need it. And what happens is they may come down here, take this off, have their new dressing taped and laid back here, remove their sutures, and pull flat. Quick and clean. So help them with that if they need it. Make sure the dressing's well covered with the rubbery tape and secure. They usually get a chest x-ray after an hour or two of the tube being out, just to make sure that there's no slow leak back. Leave the dressing intact and dry for 48 hours, and then it can just be covered by a Band-Aid and they can go about their business. That is the basics of chest tubes. Any questions? Okay.
So probably going to see them more on like med-surg.
I think you'll see more of them on med-surg. But certainly if you get the chance to help with an insertion or witness it first even, just have at it. It's quite interesting. Because they do some local and they go in with a scalpel and then pop the chest tube in. And it's always better off to have an ultrasound first to know exactly what you're shooting at, especially with the fluid pockets too. Better to know exactly where to put your tube. I can't think of anything else that we haven't covered. Okay, thank you.